Good afternoon, and as well as all the other speakers, thank you to Isokinetic for hosting this. Unfortunately, I arrived in London a little bit sick, so my voice is a bit labored, so I do apologize for that. That vodka should help. I'm a certified athletic trainer, and I'm a certified strength and conditioning specialist. I work with primarily elite, professional, and Olympic athletes from across a wide variety of sports. It's important to understand that there is a balance between these two basic concepts. And I have witnessed this at this conference, and I'm pleased to see that. As a practitioner and someone, or I would like to almost just say, as a coach of rehabilitation or reconditioning, I definitely dabble in the art a little bit more than the science. I do respect the science, but I do need to apply the art on a regular basis. I use the term the joint compromised athlete because with these knee injuries, this is just what happens. It is forever compromised to some degree. It will never be as normal as it once originally was. But as coaches might understand better, the term load compromised may make more sense to them in managing and designing the programs that they need to do once they return back to soccer or other sports, of course. So a load compromised, and with values of GPS measuring and accelerometers improving, maybe this is going to make even more sense. You're always a load-compromised athlete. Once it happens, it will always be there. The incidence of osteoarthritis is a guarantee, basically, after ACL injuries. So we need to plan that. So a team needs to have a strategy designed, accepting the fact that they will forever have a compromised knee joint. I also choose to use the term return to competition strategies as compared to return to play, because the ultimate goal here is competition. Most injuries happen in competition, not play or what could be considered team training. It's just a strategy, it's just a word possibly in nomenclature, but it does definitely shape how I may design my tactics in order to best prepare the athlete for the true demands of what's going to take place. But the reality is, it's a continue to compete, isn't it? Because it's very easy to get them back, it's often difficult to keep them back. So the continue to compete strategies are almost more important. I see quite a bit, programs that are getting athletes back at 3 months, at 4 months, no problem, very easy. Let's look at the long-term outcome at the end of the season or at the end of 2 seasons to see where that athlete is. Many aren't getting there. I also choose to use the word reconditioning as compared to rehabilitation. Reconditioning has this sense of restore, to return to function, as does rehabilitation. But an athlete doesn't want to be rehabbing for 3, 4, 5, 6 months. They don't like the term, in my opinion. I try to get that term out of there quickly. I feel rehabilitation is to restore homeostasis, ultimately, after the surgery, after the injury. It could be a 3, 4, 5-week process. Maybe all the swelling isn't out of the knee and all the range isn't there, but we are definitely on our way to restoring homeostasis. And then it quickly moves into reconditioning, which is training an athlete the way that they know how. Training is the same as rehab, and rehab is the same as training of an athlete. Return to play does appear down there, as well as does return to training with his skills, and a ball comes in. So I have a simple message, and is the main portion of the focus of this talk, on reconditioning or just training an athlete. Deceleration matters. You must control deceleration. Most non-contact knee injury and ligaments, yes, they occur during deceleration. I'm having trouble with this. Thank you. And in response to these contact injuries, or non-contact injuries that were decelerated based, the medical community got together and designed these programs with the hip, with the core, to help handle deceleration or landing mechanics and so forth. And as a strength and conditioning professional, it saddens me to think that it took the medical community to point out the fact that we were not properly training and preparing athletes, either young athletes or professional athletes. We're just talking about normal mechanics, proper mechanics that unfortunately are not normal and are not in their vocabulary to be able to handle. Most sports performance training is based on acceleration. The majority of books, or I should say is, how many books have you read on deceleration? How many reports have we read on deceleration for performance enhancement? Not many, but there's a slew of a significant amount for acceleration, isn't there? Extension, acceleration, power production, that's all performance-based. But if an athlete is injured because they can't handle deceleration, then they can't perform. This simple paradigm looks at the constant interplay that's taking place with reduction and production, of course, and the critical ingredient in the middle. What's going to happen? And the reality is every 2 to 5 seconds, there's this kind of aggressive decelerate to accelerate when we're dealing with higher intensities, of course, not just walking at the field. But we typically are coaching the acceleration off the ball, meaning our preparation for training of athletes, it's all about acceleration training and speed development. And we just leave it to actual game or play oftentimes to develop deceleration qualities. We don't really pull out on a regular basis and put the same focus and attention on deceleration. This is the problem again, and I think it's been biased and it's pushed many of the rehabilitation specialists in that in the middle and late stages, we start migrating towards what the performance guys are looking at and want to see, which is, can the athlete run? Can they run fast? Can they accelerate? And oftentimes when they can do that well, they're reintegrated back to team training. Force reduction is about eccentric and triple flexion. Everyone talks on concentric or triple extension, propulsion type movements. We need to focus on triple extension. The reality is concentric and extensions, it's easy, it's fun, it's powerful. You go, it's all about that way. Eccentric, much more difficult. Obviously, we've seen this for 2 days of talks and lectures about the inability to control and have motor control on landing and position of the hip and the core and so forth. I also want to then say, let's then just stop calling it a return to running program. Once again, it oftentimes puts a bias on the direction we ultimately go towards when it comes time for middle and late stage and return to play or return to competition. We start to just migrate towards what the run is. Once again, deceleration is where injuries typically take place, and the re-injury rate is typically taking place oftentimes within 2 months because they weren't quite prepared. So multi-directional speed and agility, if we are always approaching that, says we never allow linear running to predominate the entire progress. We're always trying to balance out, in fact, potentially have 2/3 deceleration change of direction focus and 1/3 on acceleration. Most of these athletes, when they come back, they don't have a problem accelerating. So all of these are just motor skills. They can be taught. They can be taught at a young age, like we just heard. They're more difficult to be taught at older ages. But I would like to think professional athletes have a little bit of elite development and capability within them in order to learn new motor patternings. Not all professional athletes are elite athletes. When you see this statement of it's not how fast you can do something, it's how slow you can do it correctly, well, that gives us a green light throughout the entire reconditioning process, even at the slowest modes and the slowest paces, to go ahead and coach all of the necessary deceleration tactics. Whether it's cutting, pivoting, turning, that can be coached very early. They're just not done at high intensity. Very slow, but absolutely correct. They must be coached. They have to be continuously coached. Close is not good enough. Force reduction, especially high-intensity force reduction, takes type 2 muscle fibers. We have to start attacking those type 2s as soon as possible. Arthrogenic muscle inhibition, a term that I came across not too many years ago and is gaining a lot more interest in the research, is very important for us to understand. It is beyond the scope of my talk to go deep into it, but I do encourage that you are researching it, looking at it, and starting to decide that perhaps it is affecting how we are rehabilitating, or at least how we are returning our athletes back. What happens is there's a disafferentation that comes out of a joint. Most of you have heard this and understand this, but describes the inability to completely contract the muscle. That's a problem. Completely contract a muscle. Therefore, it delays and prevents effective strategies. That is going on. The real scary part is it's a bilateral situation, as much as 7 to 26%. So when I read this and we read that the incidence of re-injury is higher to the contralateral limb than the ipsilateral limb, is that just because of Q angle or hormonal problems and all the other things? Perhaps it's just because we've never fully restored neuromuscular control of the contralateral limb as well. It's higher incidence than the ipsilateral because we have a tendency to do a better job on the injured side. We kind of ignore the other side, not entirely, of course, but we often focus on that injured side. The time scale for arthrogenic muscle inhibition happens immediately and continues on. We see that it plateaus. It's interesting as it plateaus around the 6-month mark. What a classic time for return to sport following ACL injury, both from a biological perspective, as many say, theorize, talk about the biology at that point, but perhaps it's just because they're turning on just enough that things are starting to look a little bit more normal. But the problem is it's not finished. Now, of course, these studies are done on the quadricep. These studies are not done on professional athletes on a regular basis. Hopefully, the professional athletes have much less AMI involved in them than others. And we also know is that this is not a quadricep issue. It's just the muscle that they test, and we know why they test that muscle regularly. But it is a central driven process. The hamstring is involved, the glutes are involved, the core is involved. I do believe that there's inhibitory processes taking place to the entire chain. Has to be addressed. Excuse me. Common problem that we see then. Physio-based programs, for example, traditionally, let's just look at that from a time scale of an ACL surgery, up to around 5 months post-op or so. Yes, around 3, 4, and 5. Physiotherapy is going into their 4th and 5th stages typically, and then the performance fitness trainers, they're starting to take over. But oftentimes when the plan is a return to competition that takes place at the 6-month mark, or at least return to training that takes place before 6 months, the performance training guys don't necessarily have a hold of this athlete to possibly be training them at a higher intensity than what is oftentimes occurring in physiotherapy. That should be the case because they're experts at training high intensity. So we spend quite a bit of our time training slightly less of high intensity or low and medium intensity, and it predominantly is the type 1, a little split of type 1 and type 2. As you can see, we end up spending the least amount of time in the rehabilitative process training the muscles that matter the most, that help us with deceleration. Of course, they help us with acceleration, that's a given, but deceleration typically is where that injury is taking place. Perhaps a better option to look at it, we need to get the reconditioning, the performance training people, fitness coaches, whatever you want to call it, involved a little bit sooner. Maybe that's just a name, that's a psychological ploy to keep the athlete more motivated, that's fine. But if we just stretch it out a little bit longer, I'm not saying you have to wait, 8 months, but if we just looked at that typical 2-month process, if we just got the athlete back to training at that level of high intensity, where we're getting consistent recruitment of the type of muscles we need, and if you stretch it out a little bit further, now we have an actual training block of where that athlete needs to be. I think they're coming back too soon from a neuromuscular perspective. Because just because the injury has healed, the athlete may not be neuromuscularly prepared. This isn't just about the biology, and it isn't just about function. It's about how strong you are to handle the true demands of competition. It's not about an earlier return to competition. It's about this longer preparation. And preparation to me is the highest level of training within the shortest period of time. Do no harm, of course, and then stay there for as long as you can to show stress sustainability. We need to show that they can sustain that load. Like I said, easy to get them back, hard to keep them back. 6 to 8 week preseason, so to speak. Let's ramp these athletes up, get them to where they're 100% and say, good, now you have your 6 to 8 week preseason to show that you can sustain this. Finally, combating arthrogenic muscle inhibition, we do functional neuromuscular electrical stimulation. I use a Compex unit, have for many years. We use it with squatting, with lunging. We use it with jumping, with quickness and agility. We keep it very functional. We use it early, very early, post-injury, post-operative. We do fast eccentric exercises, a lot of body weight, fast motions, 1 per second, with sandbags, with the lunges. Yes, they have to have the stability, but that's when we did it very slow. Now, as we gain the speed, we must have fast eccentric actions. Pool plyometrics, you will see in a minute. Very important. Low load, fast explosion, great neural training. And then maximum strength development. Many athletes are sent over from England for me to look at the 3-month, the 4-month, and it is often told that they're doing very well, their strength is excellent. Their strength is not excellent. It's significantly behind what I would consider sufficient, even at the 3-month mark. They always need to be stronger. The take-home message, deceleration takes priority in my mind. Joint compromised athletes, they have different strategies. We must respect that. The maintenance programs, the in-season programs are different than the rest of the team. AMI, you need to look at it and begin to understand it, and the medical community needs to continue to research it. And like I said, easy to do it quickly. Let's see if they can last. Thank you.